Good morning, everyone. Thank you for joining us for Grand Rounds this morning. This morning, I'm going to go ahead and introduce my program director, Dr. Dominique Casco, who is the program director of our internal medicine residency program, and she will go ahead and introduce our special speakers this morning.
Good morning, everyone. I have the absolute pleasure this morning of introducing our Grand Round speakers. We have Rabih, Geha, and Reza who are joining us this morning for their talk, The Math and the Magic, a Love Story, Becoming the Ideal Clinician-Educator. So to give you a little bit of background on them, Rabih is a clinician educator at the San Francisco VA Medical Center, and Reza is a clinician educator at Northwestern Memorial Hospital. Together, they co-founded the Clinical Problem Solvers, a multimodal venture with the goal of creating a culture of compassion and community to disseminate and democratize the stories and science of diagnostic reasoning. Their talk will highlight the essential ingredients necessary to become the ideal clinician educator. It is a simple formula of kindness and intelligence that is often overlooked. Their lessons are a consequence of a love affair between a mathematician and a magician. We're so excited to welcome you guys to WashU and to the Department of Grand Rounds this morning. So Rabih and Reza, go ahead and introduce us to your talk.
Well, Dr. Casco, that's an incredibly kind introduction. I think we're humbled every time the kind words are said about us and the CP solvers, and it's nonetheless true coming from you. Thank you so much. I will say, Reza, it's a dream come true for me to have a title of our talk have the word love in it, because I think while ambitious, it is true. I also now stop talking and have you say something to this lovely group of people.
Good morning, everyone. So nice to see you. Dr. Casco, thank you so much for the invitation. Ava, thanks for organizing everything. Maybe I'll start today's session by telling all of you a funny story. And the great thing about Zoom, Rabih, is that we can't tell if anyone's laughing or not. So we'll just assume that they're laughing because I have it in the full screen mode. But the other day I went swimming with Rabih and I had put on a swimming cap. And you'll soon realize why we call him the mathematician. But he said, Reza, that doesn't add up. You have a bald head, therefore you don't have friction, and thus you don't need a swimming cap. And that's what's in store for today, folks.
I will add on to your story, the lovely story, that too, Reza looks great with a needless Speedo cap on his head, which I hope that you all get to see at some point in your life, because if you haven't, life isn't just complete. And two, his head is as smooth as it looks. It really is. It just flows like no other. But I wonder, Reza, do you think we should start our talk, or should we keep telling folks stories about your beautiful bald head? Yes, I don't know how to transition to talking about our disclosures from that organic and spontaneous story, but I'll tell you that yes, Reza and I are indeed co-founders of the Clinical Problem Solvers, and indeed have a friendship and a relationship that is the source of the work that we do. And this is not really technically a disclosure. It's just that acknowledging that the Clinical Problem Solvers is in fact a nonprofit organization, and we are the co-founders. Though this talk really reflects the lessons we've learned from before the Clinical Problem Solvers and some of the insights that we've gained afterwards. And the objectives are clear. It's to talk about the math, the magic, and their love story. And I think Dr. Casco hit the nail on the head with her description of a little bit of what the ingredients are, but let's speak a little about what the math is. And when we're saying the math, we're really talking about a recognition of the intellectual intelligence required to be the best clinician educator you can be. It really is a lot of effort, and we put in decades to accumulate the medical knowledge required to be able to pass that on to our future generation of learners. And the good news is, from the perspective of clinical reasoning, it boils down to 2 or 3 fundamental things. How good are your diagnostic schema? How good are your illness script? How good are you at representing problems? And that is a fundamentally crucial ingredient that certainly isn't the only ingredient, but we'd love to emphasize how crucial it is to develop that skill set, and also how important it is to manipulate that skill set and tailor it to the people before you.
And the magic is the EQ, or the emotional intelligence. It's the first step in establishing a relationship with your learner. You see, you can have all the math in the world, all the fund of knowledge, but if you lack emotional intelligence, you cannot be the ideal clinician educator. And the same is true. You can have all the magic in the world, be the brightest in terms of emotional intelligence, but if you lack fund of knowledge, you cannot be the ideal clinician educator. So this talk is the marriage of the math and the magic leading to the ideal clinician educator. And I'll do a quick interjection on myself, Rabih. Why do we call Rabih the mathematician? Well, Rabih was a math major. And if you ever listen to Rabih discuss an unknown clinical problem solving, huge shout out to Jerome, who's doing one tomorrow at WashU. I wish we get an invitation to come and watch him knock it out the park. But we call him the mathematician because he takes a stepwise approach to solving a clinical problem and makes those complicated steps seem very simple and accessible to all of his learners, including myself.
Oh, I get to interject now. Thank you for those very kind words. The magician is called the magician because he in fact is magical. The good news is while you won't see any of our case solving skills today, you will actually be able to see the magician in action, which is part 2 of this story, which we'll tell you more about. But really, as you'll see, Reza's emotional intelligence knows no bounds. And the reason he's called a magician is because he spots people. He sees people when they're maybe not at their peak in terms of their happiness and their joy in medicine. And he's able to do that and weave narratives about his experience and how he views the world in this incredible way that, as he may tell you, but I'll set up the plant, that stems from the most cherished person in his life, his grandfather, who was actually a poet. And you can see that live on in Reza today. I heard the word marriage of the math and the magic, and I will not take that as a broadcasted proposal, Reza, but instead I'll talk about how we're going to do this. And you know, folks, when we were thinking about like how do we impart some of the lessons that we've learned, which are, you know, honestly quite familiar to everybody. It's really just emphasizing their existence and their relationship to each other. We thought in many ways. We thought we would just kind of like distill the basics or do it in PowerPoint lecture format. But, you know, I think in medicine, we need to have more fun. And the way Reza and I decided to have some fun with you all and learn is to actually act. And the reason it's fun is because we're abysmal at acting. But what we're going to try to do is actually tell you the math and the magic in 2 stories. Actually, not so much 2 stories, but 2 skits where Reza and I will play a learner and an attending. And of course, we want to engage with you as we act. So what we'll do is when we're talking to each other and in the scene, we'll be looking away and trying to make eye contact with each other. So this will be when Reza and I are play acting as if we were on the stage in front of you. Excuse me. And this is when we're looking at the camera and be reflecting with you. So again, looking at each other, we're acting and playing out a scene with teacher and learner, and then sharing some reflections with you by looking at you. You ready to rock and roll, Reza? Okay, all right. So the first story is a little bit more math sprinkled with some magic. And the second story is a lot of magic sprinkled with some math. All right, let's take it away. So folks, I'm going to set the stage. And the stage is that, that I am the attending and Reza is the intern, and we've just finished rounds. And the goal of our time together is really attending teaching rounds where we'll spend about 10 to 15 minutes usually. I'll be doing that in a few hours with my team. Where we're talking about a teaching topic. All right, let's jump in. Hey, Reza, good morning.
Good morning, Rabih.
You know, it's weird saying good morning to you as if it's the first time I'm seeing you. And again, reflective of my abysmal acting because we just spent all of rounds together. But excuse me for already messing up as I always do. You know, I just wanted to acknowledge that today was really, really busy. You had a lot on your plate. And I could see you juggling 10 different things. And I'm really glad that you're able to make some time to come learn a little bit with us. Folks, the first challenge really is to recognize that the transition between work and learning, hopefully work involves learning, there's no doubt about that. But transitioning from that mode of like rounds, getting stuff to do to learning is a tricky one. And you know, our first challenge, quite frankly, is to grab a learner's attention. How do you allow Reza the mental space to be able to absorb the teaching topic today, which will be abdominal pain? And I think that's quite simple. There's two fundamental principles. Do you pull stuff off his plate, grab his pager, take some to-dos, ask him to do a note, ask somebody else to hold his pager? And I think those strategies are very helpful. And often, from what I've seen, tools that residents help their interns and medical students too. And it's certainly something that as the attending, you can add to your back pocket. But I think what you're more empowered with as the attending is to reflect on how you can push the teaching into the foreground of Reza's mind to help him prioritize it over anything else. And that's the joy in trying to work and optimize on the quality of your teaching. And hopefully throughout this, we won't be able to display me taking Reza's pager or whatnot from him, but I'll be very deliberate in trying to have the teaching occupy the foreground of Reza's mind. So I'd encourage you, I'll really talk about myself. As soon as we're walking into that space and that learning space, I'm already asking, how am I going to have this content take up space in the busy mind of an intern? And yes, one strategy, pull things off, and the other strategy is to be deliberate about the teaching to give it shape such that it actually lands in his mind. And so we'll hopefully see a little bit of that in the ensuing moments. All right, back to the case. All right, Reza, so today, as we talked about earlier, we're going to talk about abdominal pain. And I would love to know how you think about abdominal pain in general.
So Rabih, I first start by thinking about the life-threatening causes: perforation, ischemia, obstruction, ectopic pregnancy.
Mm-hmm.
Then I take an anatomical approach to abdominal pain. So for example, right upper quadrant pain would make me think of pathology of the hepatobiliary system. Then I consider organs outside the abdomen, which may be referring pain to the abdomen, like the lung, the heart, the GU tract, the kidney. And finally, if everything is negative, specifically if the imaging is negative, then I deploy my image negative schema to abdominal pain.
Superb, excellent job. Abdominal pain is a very complicated topic and a story with multiple layers to it. How far in the story do we go? Diagnosing the learner and understanding where they're at is fundamentally important, and open-ended questions to give a sense of where people are at is so key. Now, of course, this is a scripted exercise, and I may already know where Reza is at with abdominal pain based on a case that he saw or an exercise that he's done. But the goal of this question is to really figure out how far deep into this experience is Reza, and how do I tailor it to him? And that's the key word, folks, tailor it to him. I'm not teaching an approach to abdominal pain. I'm teaching Reza Manesh, the Chipotle-loving, Speedo cap-wearing intern, an approach to abdominal pain. And there's two dimensions to that. There's getting to know the human being before me, to be able to play around with him and to throw in references to his Chipotle, throw in references to his Speedo cap while I'm teaching him, to humanize the teaching, but also to get to know where he's at as a learner. And we aren't able to demonstrate that quite today, for me to understand where Reza is at as a learner. Does he like to learn visually? Does he like to learn through auditory? Does he like to learn through a unique combination of both? Does he like to play the Socratic method and walk through questions and answers sequentially? Or does he rather like it for me to package it for him and then hear it back from him? And there's so many different additional layers to that, but it's absolutely key to take the time over the course of your entire experience, not necessarily focused on rounds, to understand the human before you, that you can personalize the teaching to their humanity, and to understand the learner before you, so you can package the story in a way that sticks with them. And fundamentally, as you develop expertise in abdominal pain, which will come naturally with the experience that you have and with hopefully reviewing some of the CP Solvers content, including the stuff before you, the goal, quite frankly, is to be an expert in the learner as you are an expert in the content. And you might find yourself that even if you're not quite the expert in abdominal pain, you're not the future GI physician that Ava is going to be, but that you are an expert in the learner, you may do a better job than somebody who's an expert in the content and teaching this specific human being an approach to abdominal pain. So I'd say so far, create the space. Ask yourself, how am I going to create the space for this learner, for them to pay attention to this talk? And then how am I going to personalize it to the specific learner? There's a lot more, so why don't we get back to the case? Rez, that was an absolutely superb approach to abdominal pain, quite honestly. And I think that your layers and layers of your schema illustrate just how many reps you've had with a specific condition. I think one thing for us to reflect on is, when you say imaging, tell me what imaging modalities you're thinking about.
I'm thinking ultrasound or CT scan.
Terrific, terrific. Folks, there's no way he wasn't going to know the answer to that question. He has a four-pronged approach to abdominal pain, not just because he spent hours and hours doing it for the podcast episode, but he really does. So you may ask, well, why did I ask that question? Why did I ask such an easy question that I know he'd be able to answer? Simple. Dialogue over monologue. Every single day, people love being engaged with and talked with, not talked at. Talked with and not talked at. It's so important within the first few minutes of a talk to establish that it's going to be a conversation, not me talking with somebody. And that really comes back to the fundamentals, how we all learn. We all learn through storytelling. And me turning this into a story where we both learn from each other is way more impactful than me sitting here and talking at you. In fact, you might realize that we're doing that strategy right now, the conversation, the dialogue over the monologue, with me interrupting my tendency to ramble away as I am right now with conversations with Reza, which grabs people's attention. It's just a much more authentic way to learn. So no matter what strategy you have to realize very quickly that as soon as you've created mental space, as soon as you've tailored the experience to the learners before you, you have to engage them too and for them to participate in the experience. And I will say there's another benefit. It's not so much just dialogue between learner and teachers, it's also creating a space where everybody feels comfortable saying something. So I also asked Reza this question because I knew the answer to it would be short and sweet. And it would allow maybe the medical student to share her opinion or for the pharmacy student who's sitting there to talk. And so the idea is to make it very clear that the goal is for no one to talk for more than 2 minutes, including the presenter. And I will apologize in advance for violating that rule right now. I'm not modeling it very well. I'm working on it. As true of everything on this topic.
I'll tell you folks, he's not improving.
You know, I need to give you feedback on your feedback, but we'll talk about that later. All right, back to the case. Okay, fantastic. Reza, I think that was an absolutely great understanding of what imaging modalities we use, ultrasound versus CT scan. And I'll also reflect with you that sometimes in very rare situations, maybe in patients who've had chronic abdominal pain or who you're worried about luminal causes, you might get an MRI. So that's another technique to reflect on. Most commonly though, we're using a CT scan. And the decision that comes up acutely is contrast or no contrast. How do you think about that?
Yeah, I feel like more is always better, but I know there's circumstances in which you don't want to use contrast. For example, if they have chronic kidney disease. Though I'm not really sure if I believe in IV contrast causing contrast-induced nephropathy. I'm still confused on that topic, Rabih. But I think CT with contrast can give us much more information. There are certain circumstances like stones, which we don't want to use contrast.
Amazing. I love that. I think that spicy burrito that you have can really throws you the edge of being a little controversial. And I couldn't agree with you. I have similar feelings about contrast-induced nephropathy, though I might shy away from saying them publicly at grand rounds with other people. I think that was absolutely superb, Reza. And I think the way you said it, quite frankly, for everybody else in the room is more, sometimes in this situation, more is the way to go. The contrast value is absolutely through the roof. And I agree with you. In the majority of patients, you probably want to use it, and just be mindful of the rare situations where it might be damaging, like advanced kidney disease. Again, a home run, folks. He will not stop. His approach to abdominal pain, 4-tiered. His answers to imaging modality, superb. The way he packaged how to use contrast for abdominal CT is superb. It really is. Of course, it comes to no surprise to us all. We know how talented and smart our dear friend Reza Manesh is. But this brings up a really, really important concept. Our focus usually in educational conferences where we have multiple people learning is the person who we think needs the most help and the person who we're trying to make sure is involved in the equation. And that, I think there's a lot of strategies out there to reflect on how you do that. But I recently came across another dilemma, which is almost the inverse dilemma, which is when somebody's doing really well, how do you ensure them their money's worth? How do you reward them for the work that they're doing and elevate them to a similar degree? And this is a concept that I learned from one of the best clinical educators in the country, I think, Dr. Kimberly Manning, who in a 2016 blog post talks about high achiever inertia. And that is necessary, and essentially our tendency to say, hey, Reza, that was absolutely superb, great job. All right, we'll call attending rounds early and we'll finish early because you already know abdominal pain. I'm gonna walk away. And honestly, I think I used to do that up until a year ago. And high achiever inertia and combating high achiever inertia may be one of the hardest things we do. It may be just as hard as reflecting on how we take somebody as a learner who's earlier in the phases of learning and elevate them to a certain degree. I think it's just as hard. And of course, if you are in that situation, you have to think of creative ways of engaging your learner. And I would say, recognize that odds are that you have multiple years of experience on your learner and you can get creative. It just is a little bit of a challenge. And quite frankly, in real time, I don't think I would know exactly how to challenge Reza and make this a creative experience. So it does require reflection. And the good news is we have a scripted way of engaging Reza now, which we'll deploy. But I would encourage you to think about somebody who's doing well doesn't mean they can't be doing better and better and better and better. And so hopefully we'll try to get Reza into a space where he can grow despite his tremendous knowledge of abdominal pain.
Rabih, one of my biggest regrets is that I can't give you the emotional applause reaction on Zoom because I'm in the presentation mode. But if I weren't, I would be giving you the applause. Just want you to know that.
Well, thank you. I don't know if you can see my blushing in my lighting here, but it's there. Very kind. Okay. All right, Reza, let's do this. You know, I will be honest with you. I'm having a hard time figuring out what I can teach you about abdominal pain. And so I think I'm going to have to take you to the extreme edge of your comfort zone. It's going to be a bumpy ride. I guarantee you that. So I'm going to ask you to fasten your seatbelt, and we're going to take a ride into a complicated world of abdominal pain. You ready?
Yes, I am.
Okay. All right, my friend. So I'm going to take you to a space that makes almost everyone feel uncomfortable, and that is the emergency triage room right there before you. As you know, I spent a little bit of time in the emergency room, and the goal in that room is not necessarily to make a diagnosis. It is to have a sense of what to do with the patient. And the reason it's tricky is because you have to come up with a decision in minutes, maybe a minute or two at most. So we're going to take your approach to abdominal pain, and we're going to have to apply it real quick, okay? So, sorry, excuse me, folks. There's a little bit of a noise outside, and hopefully it should pass soon. So here's the scene in the triage room, Reza. You walk in, you take a left, and you see a nurse that you've known for 2 years, and she looks concerned. You know her body language now, and she's worried about this patient. You then glance over, and you see a patient kind of hyperextended in his chair with his legs out. One hand, his left hand, is over his belly, and the other hand is actually holding an emesis bag. And you can see the emesis bag is 1/4 full, 1/4 full. And he really looks bent out of shape, just not well at all. We started this exercise, folks, with reflecting on how we can create space in Reza's mind. And I think a strategy where you really grab his attention in some way, shape, or form through acuity, through a riddle, through some technique is absolutely key. This is one way of pushing the learning into Reza's space. He might have been passively paying attention to my questions about his approach for abdominal pain or contrast or not, but nobody can ignore a situation where somebody appears acutely ill or somebody has an untold diagnostic story. And I will tell you that I think that's the way to start all teaching, to really not necessarily begin with a slow walk towards your goal. And the way I used to do this is I would list the objectives and kind of move slowly. But now I think all teaching should be like a plane taking off. You have to skyrocket into the world that you're going into. And that's one effective way of grabbing people's attention. Really go from 0 to 100 in seconds. Why? People listen. You have their attention. And it allows you to control the temperature in the room. And the goal is to go from lukewarm to soaring hot instantly. But I think the ideal conversation is one where you oscillate between having Reza at the edge of his seat panicking about this patient, and then kind of slumping back, relaxing, and meditating and reflecting on the content coming his way. I think all good teaching is a roller coaster ride. You skyrocket to begin with, you kind of dabble and dangle a little bit, get relaxed, comfortable, and then surprise, here you go on another roller coaster ride again. And so hopefully we'll illustrate that dance today. And now Reza is on the edge of his seat. He's like, what is happening to this patient? He's uncomfortable, as he should be. So was I. And the goal is to bring him back into a little bit of a comfortable zone, then back into discomfort and oscillate between those two extremes. So join us on this roller coaster ride, please. All right, Reza. So 2 minutes in there. What are you going to do?
Rabih, I'm going to get vitals.
Perfect. That is always the right move, my friend. Always. As Reza Manash, the podcast celebrity, has taught me, vital signs are vitals. I'm really glad that you, Reza, the intern, also applied that. So here they are. The patient's afebrile. The heart rate is 105. The blood pressure is 110/72. The patient is satting 98% on room air and breathing at 14 breaths per minute. Okay, so you see that on the monitor in front of you. What's your next move?
Robby, I would want to know the location of the abdominal pain.
Okay, terrific. I think that's going to be a really important data point. But I will tell you, this is the value, my friend, of coming into the triage room. There's actually one piece of data that you want to know before you know the distribution of the abdominal pain. And let's reflect on it this way. Another completely separate scenario. I want you to think about a patient who's altered. First, a patient who's altered for 1 hour versus a patient who's altered for 10 years. How does that change your analysis of that specific patient?
So for the patient who's altered for 10 years, I would be thinking about a chronic neurodegenerative process. While the patient altered for an hour, I would be thinking about an acute metabolic disturbance.
Beautiful. My friend, Albert Einstein taught us to understand the universe as a space-time continuum, and I will tell you that applies to diagnosis too. You really can't make any progress at all without knowing the space, and here the space is abdominal pain, but just as important as the time course. So I would say whenever you're thinking about a diagnostic problem, before you think about anything else, you need to know the space, here abdominal pain, and just as important, the time. Folks, correcting answers is tough. Sometimes it's a judgment call. Sometimes the answer isn't necessarily correct or incorrect, but it's the way you operate. And I will tell you that the formula that I apply is a formula that is out there in the literature, and I will share it with you. There's always truth in an answer. There's always some truth in what the learner is saying. Find that truth and start with that. Build with that being your fundamental anchor. And sometimes the truth is the effort. Sometimes it's like, oh, you know what? You really thought about that very hard. And this is the reason that it's slightly off, or this is the reason it's incorrect. But there's always truth. That's point number one. Point number two, celebrate the fact that you're teaching your learner. Do it with a smile on your face. It's not so much, oh, you got that wrong. It's actually the time course. It's, oh, you know what? I actually have something to teach you. In this specific instance, you were off. And that's okay. That's what we're here for. I'm going to teach you that time is more important. And I didn't quite do this now for the sake of time, but always end with questions. Whenever you're teaching somebody something new, your goal is to make sure they learned it. And if they don't reflect back with you, they may not have learned it. So if the answer is slightly off, acknowledge the truth in it. Teach with a smile on your face and the joy that it is to impart something with somebody, and then make sure they learned it by asking questions. Okay, I'm going to give him something that he actually is going to get right this time. So let's go back to it. Okay. All right. So in this case, Reza, this patient actually had abdominal pain that began a couple hours ago. Let me tell you a little bit about what data we collected in the room. So he developed diffuse abdominal pain fairly acutely. It began about an hour after he woke up this morning, 2 hours ago. He's had a lot of nausea and vomiting, and he really hasn't eaten anything at all since he woke up. We do a quick exam, and he has no surgical scars. He's kind of tender everywhere, diffusely throughout his peritoneum, but throughout his abdomen, excuse me, but he has no peritoneal signs. All right, Reza, you're in the triage room and you're thinking about this patient with abdominal pain. Let's get another rep in. Why don't you share your approach to abdominal pain again?
Yes, Robbie, so it's the 4 buckets. The first bucket is life-threatening causes. Here with nausea, vomiting, abdominal pain, I'm most concerned for obstruction. The second bucket, which is based on the anatomical distribution of the pain, I'm not getting a sense this is localizing to a specific organ. I always am worried about extra abdominal causes of abdominal pain. And then finally, we don't have any imaging yet to even deploy the schema for image-negative abdominal pain.
Absolutely superb. Fantastic. Folks, this is the dance between discomfort and comfort. We brought him to the edge of his discomfort zone, and now we needed to make him a little bit more comfortable. Asked him some tough questions. Actually, I had him answer a question incorrectly, and I needed to bring him back. And now he's probably not on the edge of his seat. Now he's like, yeah, I know abdominal pain, and I can even know it when I'm here in the triage room. So again, now I have his attention. I have him a little bit more relaxed. So Reza, that was awesome. I'm glad you could apply your approach to abdominal pain, even in the stress of this situation. I got to tell you, there's one thing that we need to do in the triage room now. One thing before we go to a bed. What do you think that might be?
An electrocardiogram.
Fantastic. Tricky question. I'm really glad you got that right. Asking a closed-ended question to one person is always tricky. But again, wanted to push him back in his zone of discomfort and Quite frankly, I would never ask that question if I didn't know that he trusted me. And so again, here's the value of investing in your learner, both as a human being and as a learner. You can take risks. That question, a closed-ended question to one person, is a risky question. It's an important lesson to impart to an EKG not to miss a myocardial infarction, but it's a risky one to impart. And there, I'm glad he got it right. And I could only ask it because I wanted to bring him back to a discomfort zone, and I know he trusts me. So Reza, the EKG showed sinus tachycardia. I will tell you, the patient was then moved to a bed, had an IV placed, but we missed something. He walked out of that triage room, was rolled out of that triage room, and the diagnosis was right there before our eyes, and we should have seen it. By we, I mean me. I should have seen it. And this was a case of abdominal pain that I actually missed the diagnosis on, and I'm here to teach you on it. I'm going to actually let you be and let you go back to your work and not tell you what it is, because I want you to reflect on what it might be. And I would also love you to reflect on the conversations we had about imaging and the nature of imaging, and to practice all of this again. But think about it. What could we have missed in the triage room? What slipped underneath our radar? I used to think that all teaching needs to end with a gift, a neatly packaged, tightly wrapped gift. The plane has to take off to engage your learner, but please don't ever land it. Always end with questions, not with answers. I think learning is lifelong and goes on forever and ever and ever and ever. And giving the opportunity of an unanswered question in Reza's mind to percolate throughout the rest of the day is an opportunity I will never let pass. Of course, that opportunity comes with the responsibility of closing the loop with him later and making sure that I tell him what we missed in the triage room and not have him agonize over it. But I think it's absolutely key. Always end with an open thread, with a question, not an answer. Don't land your plane. Keep it flying with Reza forever and ever and ever. Now, that's incredibly cruel to have you sit through a case of abdominal pain and not tell you what the answer is, my dear friends. So if you really, really want to know, shoot us an email. I promise we'll get back to you and tell you what this patient actually had. But maybe, Reza, we can come to you and have you reflect as a learner what you got out of this experience.
Well, first, I want the audience to know that you deserve an Oscar for your acting. It is, 5:30 a.m. Pacific Standard Time. So I thank you for joining me this early, Rabih. I thought throughout that interaction, there was both emotional intelligence and intellectual intelligence, the EQ and IQ. I felt as a learner that you cared about my progress. And even though I may have had a great approach to abdominal pain, you pushed me beyond that approach. And I also felt you were invested in me as a learner because you gave me tasks to complete. And you let me know that our relationship, like that plane that never landed, is still not going to land.
Very well said. I will take you flattering me any day, even at 5:30 in the morning. Keep going. Thank you. That's very
all right, folks. We're going to jump back in the plane. This time we're flying first class and we're heading east from San Francisco. This book, I highly recommend that you read and that you recommend it to your learners. Mistakes were made, but not by me. Why we justify foolish beliefs, bad decisions, and hurtful acts. If we were in person, I would ask, how many of you have ever made a mistake? I know we're not in person. I still want you to raise your hand. It's good exercise. And the truth is, each one of your arms should be going up. We have all made mistakes. You see, we, like every other human being on this planet, are not perfect. What happens when you make a medical mistake? Well, usually there's a consequence to it. How can you, as the clinician, deal with that consequence? Has anyone ever taught you with how to process a medical mistake? In the following story, I share with you a resident who came to my office crying after making a mistake in the emergency department. We were on service together a few months prior to his ED rotation. All right, Rabih, let's go.
Hey, Reza, can I talk to you about something?
Of course, come on in, Rabih. Please grab a seat.
Thank you. I really appreciate you letting me just come on in here. This is going to be so hard to say. I missed a case of an epidural abscess in the ED yesterday, and I just feel terrible.
Tell me a little more.
Well, it was a patient who had come in from a nursing home, and he had advanced dementia. And the sign out was from the ED that he came in with altered mental status, and kind of worked him up for that. And he was pretty altered. And the next day, I signed him out to the team, and the next day I learned that that the team, when they first saw him, noticed that he was not moving his legs, but moving his arms. And so they got a spinal MRI, and there was an epidural abscess that I had completely missed.
Folks, imagine this scenario. How would you respond as a clinician educator? Very tough situation. There's really no right answer, but there are wrong answers. If you have an ounce of judgment in your voice while responding to your learner, you've committed a mistake. You may say, well, Reza, we have to judge the learner. No, you have to assess the learner and provide feedback. But in his current emotional state, he's not ready for that assessment. Another wrong answer would be to falsely say, you, the learner, didn't make a mistake. That would be a mistake as well. So what I ask you to do is think, how would you respond to the situation? Let me show you how I responded. Rabih, thank you so much for sharing with me your vulnerable thoughts. Mistakes are very difficult to process and very challenging to grow from. Do you mind if I share with you a mistake that I committed during residency?
Please do.
Folks, right now, your learner is in tears. They've just committed a mistake. Here, you need more emotional intelligence than intellectual intelligence. This learner is too vulnerable for you to assess their clinical decision making. Look, this is not about me. Why am I trying to share a mistake I committed with my learner? It's to normalize the act of mistakes, and it's also to reassure Rabih, my learner, that even his mentor or his attending or his coach also makes mistakes. So let's go back and I'll show you what happened. So Rabih, during my intern year, it was around December, we had admitted a patient with end-stage renal disease on hemodialysis through a tunneled catheter who had fevers and chills. Blood cultures showed bacteremia. The plan was very simple. Remove the line, give antibiotics, wait until the blood clears from bacteria, and then reinsert the line. So every day we were obtaining a chemistry panel. On day 2, the potassium was 5.4, and I received a page from the nurse. And of course, I panicked. 5.4, Rabih. So I ordered a stat EKG, and the T waves to my eyes were peaked. So I put the patient on telemetry. I gave the patient calcium gluconate. I gave the patient lactulose, and I gave the patient insulin. And I remember I left the hospital that day feeling very confident in my skills and thinking that I finally become a doctor. I come in the next morning to get sign out, and I see that the patient is not on the list. And immediately my heart dropped. I knew I did something wrong. So my colleague told me the patient went down for their procedure, had the line placed. When they tried to awake the patient was unresponsive. They obtained a point of care glucose, and that glucose was 24. The patient was given an amp of D50, transferred to the ICU on a D10 drip. Rabih, my initial reaction was that I did not want to practice medicine that day. I just thought about the oath we take, first do no harm. And here I was putting someone in a hypoglycemic coma. And I became tearful. And I just wanted to leave the hospital. I just wanted to walk out of the hospital and not return. But then, through some cognitive behavioral therapy on myself, I told myself the mistake would be not learning from this mistake. I owe it to this patient to learn from my mistakes so I don't commit them on the next patient I take care of. So the first thing I did was I went to our best cardiologist at the time to show them the EKG, which I interpreted with peak T waves. Before I could put that EKG down, Rabih, before it hit the desk, she looked up at me and said, Reza, those are not peak T waves. Peak T waves hurt when you sit on them. And always remember to compare the EKG to the prior EKG. So that was mistake number one, Rabih. I misinterpreted the EKG. Then I went to my attending on service and I said, look, I followed the rules in the handbook. It says give insulin if the patient is hyperkalemic. They said, well, Reza, a potassium of 5.4 isn't too high. You don't need to treat that aggressively. And by the way, patients with kidney disease have impaired gluconeogenesis and impaired clearance of insulin. Therefore, if you give them the usual 10 units, you will drop their sugars. In fact, 75% of patients with hyperkalemia and end-stage renal disease on dialysis who get insulin become hypoglycemic. That was my second mistake, Rabih. One, I misinterpreted the severity of the potassium. And the third, I didn't account for the patient's end-stage renal disease and the effect it had on glucose homeostasis. Folks, at this point, my learner stopped crying, and started to sit upright with some confidence. And my learner asked me, so Reza, what are the next steps? I said, first and foremost, you can't interpret your decision-making when you're too emotional. It's too difficult to be objective. You're gonna blame yourself more than you should. So wait for your emotions to subside. And when you feel you're in the right emotional state, come back to my office and let's talk about your clinical decision-making. And the learner was very happy with that plan. So a few days later, the learner appeared at my office. And this was to perform the cognitive autopsy. Sorry, Roy, I'm gonna have you look at the audience again because I want to nail this term. I love the cognitive autopsy. We're not literally taking a scalpel to Rabih's head, though we would find in a brilliant brain. This is just analyzing our decision-making, the cognitive autopsy. We've learned this term from our mentor, Gurpreet Dhaliwal. Rabih, I want you to tell me exactly what happened at time point 0 when you met the patient.
So, I walked in, I heard altered mental status. I saw the patient was altered. And so I was in the world of why was this person confused? And that's kind of the mental space that I was in.
Tell me, what's your approach to altered mental status?
Reza, there's this kind of above average podcast called the Clinical Problem Solvers. And they have an above average episode narrated by an average person about an approach to altered mental status. And it goes like this: M for metabolic, I for infection, S for structural, and T for toxin. And that SMIS schema is kind of what I was using in real time.
Folks, so you see, we're in the IQ portion of our talk. We took care of the EQ, now it's the IQ. And here is our frameworks to abnormalities in medicine. Basically, what's the most important procedure an internist perform? Well, one of the most important is thinking, is diagnosing. Patients want to know what they have, what's the course, and is there any treatment? So here you see a framework for altered mental status. This is essentially our checklist manifesto, but a little more complicated than a simple checklist because you have to incorporate mimics. You have to incorporate base rate of disease. How common is the disease? The tempo of a disease, the seriousness of a disease. So it's this really three-dimensional way of thinking about abnormalities that present itself. And Rabih already eloquently discussed the MIST. And even within the MIST, you'll see there's memory aids here. We've all seen a chem panel. So this allows you to remember some of the electrolyte disturbances that lead to altered mental status. And Rabih, as much as it pains me to say, sometimes treatment trumps diagnosis. We in fact have an attending that said A stroke ain't a stroke until 50 of the 50 is given, referring to glucose, because hypoglycemia can mimic stroke. Okay, very good. Let's continue. So, Rabih, what happened next?
So, it was actually late in the night. So I kind of sent the work up, the basic metabolic panel, looked at the meds, etc. And then I signed them out to the team and left for the night. And I woke up the next day and I saw the note that they had seen the MRI. And I saw the MRI and I saw the note that they had noticed weakness. And that's when I learned about the epidural abscess.
So tell me, Rabih, why didn't you perform a neuro exam to pick up on the weakness?
Well, the patient was altered and I was told he was confused. And so I just focused on that, I couldn't, it was such a dominant thing that I don't think I zoomed out from it at all.
I can totally see that happening. And it's really difficult in a patient who has dementia because they don't have much cognitive reserve. And the slightest insult may push them over. It's almost like someone with chronic kidney disease. They don't have a lot of nephronic reserve. And so the slightest insult may push them over. But, Rabih, most diagnostic errors occur because of cognitive or system-related issues, or a combination of the two. Where would you categorize your medical mistake?
Reza, you've taught me that clearly there was a cognitive component, and especially I love that pearl about the reserve, and I think that was a big cognitive dimension. And I think also that the communication between nursing home ED and myself could have been better. I assumed the patient was just altered, but the data was there that he was weak too. I think that would have helped.
Beautiful. Folks, I then referred Rabih to this incredible book, The Invisible Gorilla. You can also watch the YouTube video, but it shows and demonstrates when we focus on one abnormality, we may neglect the obvious. And then I said, hey, Rabih, the hypoglycemia wasn't the only mistake I've made. I've made many more mistakes. In fact, I have a sequel coming out soon. Not really, but it should be. And I referred him to my article of all the mistakes that I've committed. So Rabih, how did that feel?
Oof. I promised everyone that they would feel the magic today, not so much the math, and that was magical. I think folks, you see why we call Reza the magician. I think that he does this better than nobody else. And there is no script. I'm not reading, as you can tell. And I think that the key question also is to reflect on not just the brilliance that you saw now in terms of connecting with somebody, but also asking maybe a deeper question, which is, how did Reza create the space, or how does a clinician educator create the space that the learner comes there in the first place? We didn't talk about that, but this learner showed up, knocked on Reza's door unprompted, spontaneous, and knew that he would be accepted and that he would have the opportunity to reflect. And that's not so much a rhetorical question. There's an answer. And that's where the math meets the magic, where the learner knows that they will have their emotional and intellectual intelligence of the clinician educator on their side and on their benefit. And the question is, how do you get there? It's a lot of work. It's a lifelong journey. That plane never lands, but we think there are 5 key components that we'd love to review with you.
And the first one is small talk before med talk. This just goes back to EQ before IQ. You need to first invest in the person you're teaching before you can teach your learner.
You have to be available. Have to. There's just no other way. If you're trying to understand the human being before you and the learner before you, there's no other way than just being present. And how you choose to show up, how you choose to make yourself available is totally up to you. It's a personal space. It's a personal decision. But there's no shortcutting around just giving your learners a lot of time. Building from the ground up. I think we in medicine have a tendency, as we should in some sense, to have a bias as to where our learner is. MS3 is always here, MS4 is always here, an intern is always here, but that's not necessarily true. You have to find the ground for your individual learner, and that's part of the exercise that you're doing in understanding them. So don't assume that an MS3 understands everything that at an average MS3 level. They may be far, far, far more advanced, or maybe not. So you have to find where the ground is, and then that's when you start building. Don't build from an incorrect ground. find the ground and build up from there.
Never judge. Definitely assess, but don't judge and criticize. Just to share a quick example, I was a third-year medical student, had just started my clerkship rotations, and I was working with an attending who was very famous at the university I went to medical school. He asked me a question. I gave an answer. He looked at me and said, Reza, how many years off did you take before starting your clerkship? I hadn't taken any time off. So from that point on, I try to hide all of my knowledge deficits with that attending so I wouldn't be judged. So it's really important you create that space like Rabih showed in the first example where I gave a wrong answer, but I wasn't criticized. I was provided feedback.
Here's the key ingredient. If you do all 1 through 4, but you're not humble, it goes nowhere. Humility is a demonstration that you yourself are vulnerable, that you yourself are open to growth, that you too, that your plane is flying and has never landed. So absolutely key ingredient is to put yourself in the space of a learner, to put yourself in the space of vulnerability, and that you too have a lot to learn and grow. So of all things, remember, make sure you maintain that humility. At the end of the day, as you can see, this is not a complicated list. What's complicated is how you do it and how effortful it actually is. But the ingredients are key, math and magic. There you are. But in reality, the truth is even simpler than that. And it comes down to what we think is one quote that's often attributed to Teddy Roosevelt.
No one cares how much you know
until they know how much you care.
And folks, we have great news. I have not lost any more hair 30 years in the future.
And all my wrinkles are from the magician.
Thank you so much.
Thank you so much, Rabih and Reza, for that wonderful talk there. We can go ahead and transition. We have a little bit of time for questions and answers here. Everyone feel free to use the chat or use the question and answer tool to send any questions our way. I'll go ahead and get us started. So I love this formula of the EQ plus IQ in order to impart knowledge and clinical knowledge to the learners. What do you do in situations where you feel that the learner needs to expand on their EQ? How do you teach someone to develop EQ?
Rabih, maybe I can share an example. I was once on service and I had a junior resident who always interrupted the intern, never applauded them on doing a good job, and always criticized the intern. And in fact, that intern now has been selected as chief resident. So what did I do? I'd ask the senior resident to come into my office, and this is not at the end, it's not the end of rotation feedback. This was literally, the day it happened. And I sat down with that senior resident and I said, look, your IQ is terrific. You're a competent physician. I trust you with the medical decisions, but you're not treating our intern with the respect they deserve. And Ava, I didn't just leave it at that. I gave specific examples that I kept track of. I said, remember at that point when you said that in front of the patient, would you like someone to say that to you? So what I want you to work on is your emotional intelligence. Treat that learner the way you would want to be treated when you were a learner. So my approach is to be very open and honest, though realizing it's very difficult to change someone's emotional intelligence, much more difficult than intellectual intelligence, but you have to do that because if you don't, then someone else is at risk of being hurt.
Thank you for that advice. I think that's definitely something I can utilize going forward, especially this year going forward. Another question I have is in regards to time management when teaching on the wards or teaching in any busy clinical scenario. How do you go about prioritizing teaching without letting rounds last all morning or into the afternoon?
That's another fantastic question. You're quite on a roll here. I would say that, growing up, my favorite thing to have was honey. And the reason I loved honey is it's sugar, but it's so concentrated. You can literally have a drop of honey and there's so much joy and sugar in it. That for me is all about teaching. I think Kimberly Manning does this best. She talks about bite-sized teaching. And I think the most high quality teaching is honey. It's not Splenda and a whole Diet Coke diluted over. It's really concentrated. So I think that I think everyone is served better when teaching happens for no more than a minute or two per patient. And that's what I strive for. And I would say, try to make your teaching as sweet as honey, and I think you'll be A-okay.
We've got a question coming in from Dr. Escoda himself. He says, nice to see you guys. So his question is, what do you do if the learner doesn't show vulnerability and humility in the mistake he commits? How do you teach the learner to learn from the mistake?
I think that's, well, hello, it's so great to see you. I wish I could see your video. And I don't know if I'm doing something wrong not to be able to do that, Jerome, but I think that's a phenomenal question. And I think that the approach, the easy way out here is to assume that you know the DX. So when you observe that behavior, you're like, oh, this person is closed to their growth. And I would say that like any kind of data point in medicine, there is a DDX for it. And I would not be surprised if a tremendous amount of insecurity and vulnerability is shielded behind this illusion of certainty and knowledge. And so I would say my first approach is to ask, what is the cause, and explore what is the cause of this appearance on the surface of this learner not learning from the mistake. And I will tell you, I don't think there's any data out there, but my experience would tell me that the cause is actually much deeper vulnerability than one would suspect. And so I think I wouldn't have an approach, I wouldn't have an RX for that condition because the DX is not readily apparent. So I think it would be crucial to be available to spend some time and understand what is the driver of that behavior. And in very rare circumstances in medicine, the driver of that behavior is something very sinister that may sometimes escalate to having to involve the school. But I found that to be very rare, and I found that a deeper insecurity often underlies a surface of confidence and a perceived lack of intention to grow.
Okay, and I think this might be the last question here. I went ahead and did invite Dr. Escoda up to join us as a panelist. I'm not sure if he's going to show himself or not. He might be busy this morning, but he's here. The last question is, how does a clinical educator increase their EQ? My question before was talking about imparting that knowledge to learners, but I think we all can kind of work to also improve ourselves and make sure that have the best EQ possible. What are your tips for that?
Justin, thank you so much for asking that question. I think it's a phenomenal question. And it goes back to any skill. So emotional intelligence is a skill that you can improve. So for example, I remember once I delivered news that a patient unfortunately had cancer, and I felt something was off there. I just felt I didn't do a good job. I went back to the room, talked to the patient, apologized, and asked them, did I do something wrong? And they provided me feedback. So just like any skill, you need to refine your skill set. And so for emotional intelligence, let's say your learner cries on rounds, or you notice their learner is withdrawn, you're reading the body language. Take the learner aside in private, ask them, what happened? What did you do wrong? Or what made them feel vulnerable or affected? And get that data and see if you want to change your approach the next time with the learner. So it's like anything in life. When you take that shot, you need to go see if it goes in or not. And Rabih, I'm referring to basketball, goes in or not. If it doesn't go in, then you can refine maybe the arc of the ball or the motion of the hand.
Okay, thank you for that. So we have one more question. Before we get to that question, I'm going to go ahead and share my screen so that people can get credit for being here and can go about their day if that's what they need to do. But those people who'd want to stick around can also just hang out with us here a little bit more. So let me pull this back up. Okay, so this question's from Mohit, who I also invited up to join us. Can you share how you intentionally create small talk and learn about your team as humans when you work each day or at the beginning of service?
I'm going to have Rabih take this question, or I'm going to ask him to. And I just want to say hi to Mohit. I feel like we're on Clinical Problem Solvers VMR right now. It's very nice to see you, my friend.
Mohit, look at that smile. Hello, hello. Good morning. Wow, it feels like hanging out with old friends. You know, Mohit, I think the short answer, because I know we're compressed on time, is to watch the first 2 minutes of VMR. And you see that kind of skill set being displayed there, where that comes from practicing on the wards. And what drives it is a deep-seated curiosity in the individual. You can't fake small talk, I don't think. I think you can do a decent job at it if it's not genuine, but I feel like showing up to wards as a clinician educator is like showing up to meet your family, and you want to get to know them as well as you can. So I think the surface manifestation is that of deeper curiosity within of who this person is, and the recognition that if they aren't there, then you as the clinician educator are probably going to do all the notes, discharge summaries, and all the work. So gratitude for them being in that space, and just a genuine curiosity. And I would say to tap into that curiosity, because any human being, if they're going to spend weeks with another human being, is going to be curious about who they're standing in front of. That's just how our brains work. And so letting that come out, as opposed to suppressing it because it feels like the right thing to do, is it really, I think, is as simple as that. And I think the biggest takeaway, by the way, is the sheer simplicity of everything that we're talking about. And it just so happens that because of social constructs, or just the way that things happen, that they don't surface. But I think my answer to your question is, Mohit, I know you have this in you, and I know you're probably doing it. And if you're not satisfied with the way you're doing it, it's probably because you think you have to do other things, when in reality, focus on that and you'll be A-okay and happy.
So we have another, I feel like I just can't stop with these questions. If I don't want to suck into your guys' time here, but we'll say that this is the last one. This is from an MS4. They say, I felt we are judged, especially as an MS3, as we're getting evaluated on absolute levels of knowledge, making me feel less encouraged to ask questions and verbalize my thought. What can attending or resident grading med students do to improve this educational environment? And I think you touched upon some of these concepts as well.
Mitsu, that's a terrific question. Thank you for asking it. For all the senior residents, all the attendings, what can you do to improve the environment? There's a few things you can do. You should never make any question feel like it's a small question. In fact, if a learner asks a question that you think they may be judged from others, share an authentic story where you made a mistake or where you had a similar question, to normalize the playing field. And be very explicit that you're not necessarily judging their questions and grading them based on the types of questions they're asking. That is crucial. For me, identify where the learner is at and then build from there without judgment, though of course you have to assess and provide feedback. And unless you do that, amazing students like Mitsuru won't share their knowledge deficits. I won't share my knowledge deficits. And that's something, if you really want to see a master perform, come to our virtual morning report and watch how Rabih responds to learners and even others who give the wrong answer. It is magical, abracadabra.
So I think abracadabra is the best way to end our grand rounds this morning. Thank you so much for joining us here. I think I can speak for everyone when I say that we're all very inspired to go about our day and take a lot of these principles with us to teach our learnees and take great care of our patients. So thank you again.
And Rabih, for my last trick, you see the hand, now it's gone.
Thank you, folks, for having us, and we'll hopefully see some folks in a couple hours for our meeting.
Yep. Bye.